Welcome to the Bullitt County Health Department's Diabetic Defenders Workshop Series. We are so excited that you've chosen to join us. Diabetes health education is a very important topic here at the Bullitt County Health Department. In Kentucky, over 14% of the adult population is already diagnosed with diabetes. That's twice as high as the population amount in 2000. Kentucky currently ranks 13th in the nation for the adult population with diabetes. Because of these numbers, the Bullitt County Health Department has taken an initiative to help defend our diabetes population here in Bullitt County. We have created this workshop series to help build the skills that you need to take control of your health and take control of your diabetes care management. We want to welcome you to this recorded workshop series hosted here at the Bullitt County Health Department in November of 2024 for Diabetes Awareness Month. Please be sure to listen to all 4 series workshops as they were very helpful and equipped each and every resident that was able to attend with the skills that they needed to take control and become a diabetic defender. Enjoy the series.
Today. So, and been here since 98, like I said, and after, I always say GE brought us, GE brought us to, and since then, of course, my husband is a chemical engineer. We have 4 children, and they've grown. Kentucky is home for them because they were raised here, even though 3 were born in South Carolina and 1 was born in Louisville, but they see this as home. Yeah, I love endocrinology. I always laugh that one other medical specialty was my kids laugh when I say it was my first love, but endocrine was my second. I would say cardiology was my first, but because I want a family, I chose not to do it. Cardiology, thank God I didn't. I prefer endocrinology. And as you know, diabetes has grown a lot, yes. So diabetes, as most people, everybody did this, it's called sugar problem. That's what most people say. You have sugar, you don't, regardless of anywhere in the world. I give talks outside the country as well to educate people, and you'll be surprised how much, because there's another type of diabetes that is not with hyperglycemia. And what's the definition? I'm going to assume you don't know anything. It's a metabolic disease in which you have an inappropriate elevation of blood glucose, and it's over a period of time. So in other words, if it's Thanksgiving, you've had everything very high sugar content to eat and your blood sugar is a little high one time, that does not qualify, although we'll talk about that. But you have to have it consistently for a while. And there are different types. And of course, this is beyond the scope of this to tell about everything. But I like people to understand, because when we make decisions about your treatment or what we should do, then you know how we're thinking. And I like to let my patients understand how I'm thinking. So there is broadly type 1, which is what we used to call juvenile onset. And there's a reason we changed that, because we know it can show up anytime in your life. There is, and that's usually autoimmune. Auto meaning self, immune, immunity fighting your own body. So it presents with low insulin, high blood sugars. Then we have type 2, which is what most people are familiar with. So to say, which we used to call it adult onset. We know that's not true anymore. We can see it at different ages. And then we have gestational diabetes mellitus, which is still diabetes, but it's only high blood sugars in pregnancy. And you really can't call that diabetes because it resolves after pregnancy. It shows up during pregnancy and it resolves after pregnancy because it has to do with some of the hormones of pregnancy. Then the latent autoimmune diabetes of adults, you hear us call LADA, some will call it type 1, and you have, that's like the type 1 in an adult. And, that has fooled me. So routinely in our practice, we'll look for that, because you can't say the patient is thin or heavy. You could come in any size. You could come slowly. So the old textbooks will show that when people have type 1 or insulin deficiency, they come very sick. We know that's not always true, because these days people get tested regularly. Then you have high blood sugars because of other medications. What's the common medication people take that will cause high blood sugar? I'm not going to be the only one talking. So what's one common, and there is no wrong or right answer, what's one common medication people take that can cause high blood sugar? But which one? That everybody get it.
Well, I got diabetes because of the medicine.
What was it?
Smoshulin lanreotide.
Lanreotide. That's it. I'll talk about that. That's You guys are too smart. I don't want to talk about that, but that's true. That's a side effect because it blocks. But the common, probably you've taken this week or so, this year somebody steroids, prednisone.
Oh.
You go, you get the flu, you get sinuses, get prednisone. You have arthritis, they inject it in your in your joint, they put it in your back, raises your blood sugar. If you have already have a tendency, guess what? Not everyone. So medications can do it. Lanreotide can. You're right. Octreotide, because of the way they work, they will make your insulin not work effectively. Yes. So you're right. Then this comes to what you're saying. Diabetes can be caused by other diseases. Yes. Exactly. Yes, ma'am.
So when it says the like autoimmune diabetes
Mm-hmm.
in an adult, like I catch everything. I got Bell's palsy.
Mm-hmm. I saw that was. Mm-hmm.
Is it kind of stuff like that?
No.
No.
So autoimmune, you're right. So people would always say, let me finish this and I'll come back to that. Diseases caused by diabetes caused by other diseases. Like she said, pancreas. You've had people who have Cushing's disease, which is abnormal cortisol, pancreatic tumors, acromegaly, high growth hormone, different other things that is not really diabetes, but they have all those. That's why I put disease of the pancreas, adrenals, pituitary that can raise blood sugar. And we think about all of this. Now, to come back to autoimmune, autoimmune means auto, self, immunity fighting itself. And I always explain autoimmune is just one category of a disease. So the type, so we say latent autoimmune diabetes of adults, which means it's an autoimmune diabetes like the type 1, but it's showing up in adults. And they don't make insulin as well as the type 2s. They invariably they need insulin. So if I walk in most times and the patient has come in referred, I've had diabetes for 10 years. They are thin, they are not overweight, and they can't get you controlled. And they're doing all their best. It raises a flag. But I don't even wait for that because I've seen it in different kinds of people. Yes, so we think about that. And that affects the therapy. This is the burden of the disease. Every time I review this, you get blown away. And this is all over the world. I give talks internationally. About 38 million Americans have diabetes mellitus. That 486,000 plus really is just for adults. That doesn't include children. So this is adults in Kentucky, okay, which 13.1%. About 101,000 have diabetes and they don't even know it. They go in, and some wouldn't go. We all have those in the family. And some have pre-diabetes, which we're going to talk about. Over 1 million have pre-diabetes. And this is about 34.1% of adults. That's a little scary. That means if you say 35, that's like a third. 3 out of every 10 people would have pre-diabetes. They think it's more than that. Every year, about 20,000 plus is diagnosed with diabetes in Kentucky. That's I actually think that may be an underestimation. That's a lot. That's a lot, yeah. And that's not just here. This is the cost burden. It's $5.2 billion in Kentucky. Stroke, amputation, end-stage kidney disease, blindness, death. All of these things can happen in diabetes. But I was talking to a pre-med student, pre-med student, I was saying, have you seen Still Magnolia? She said, no, I haven't. I said, you have to go watch it. I mean, everybody's seen Still Magnolia. They've made it in a few other versions. And because in that movie, have you seen it? Yes, because in that movie, they make it sound like Julia Roberts couldn't have children. You and I knew she could have children. But what they were saying is she had complications. And and they didn't clarify it. If she has children, the complications were going to advance. But she thought they meant she couldn't have children. And if you remember Dolly Parton and all of them in the beauty parlor saying, oh, what do they know? And they said she couldn't have children. But the mother kind of understood it. It's the same way. I always give that story because of all the complications that diabetes could cause. But we know differently now that we can stop this. That is not true. I have patients give birth to babies all the time. Twins, all kinds of babies. In fact, I always laugh. I want to get you pregnant. Have the babies quickly. Let's get it out of the way. Because they get the babies. If they do what they're supposed to do, they get babies. Unlike what we saw in that, because we have more that we are doing now. So I don't want to say too long, but this is international. This tells you 57 million people live with diabetes today. It's a lot, all over the world. By the year 2045, 700 million people will have diabetes worldwide. There has to be something. It leads to over 4 million deaths per year. It affects all ages, communities, continents. I was telling you. In fact, I just turned down an invitation to do something with Nigeria for a ministry for diabetes. They gave me 2 shots of a notice, so I turned it down. So it's all over. It's not just the US. Now, yeah, do you see? Yes. Because why? So I say why? Why do people develop diabetes? We've kind of talked about this. It's autoimmune. There's a genetic predisposition. So this is what I also tell my patient. You could say maybe that's my own way of putting things on personality. I always say to patients that you come in, don't blame yourself completely, because 60 to 70% of your risk of developing diabetes is genetically determined. It's just who you are. To 70%. It's significant of type 2, talking about type 2. Even type 1, there is HLA, there's a high chance, and I don't want to quote because I wasn't focusing on that. So we know that. So I have people, when I say that, they burst into tears, because all their life they felt they were not very disciplined. They just didn't do it the right way. I just didn't have the will to do it, blah, blah, blah. Now that's true. And I will say the genes you and I can't change. We don't choose the family we were born into. Now, we say that in 2024. Fast forward 6 years, I don't know, we may be able to do gene therapy. I'm not going to say that, but this is 2024. Genetically, we can't change. But what can you change? Lifestyle, that contributes, your lifestyle. Obesity, medications, diseases of other organs, what we eat. I like food too. I mean, don't like me, but but what I'm saying is that, so we can't change the genes. You can't even change the autoimmune, but you could change those other things we can talk about. So if you told me, oh, you have a risk of diabetes and I'm treating you for bronchitis, I may say, oh, let's try other things before we do steroids. Do you see what I'm saying? Or if you already have diabetes, I may say, let me think about how I'm going to adjust your diet before we do steroids. So I know that I can adjust. But the genetic portion of the type 2, there's nothing you and I can do. Okay. Believe it or not, that also has to do with weight. 60 to 70% of weight, how you carry weight, how you gain weight, etc., is also genetically determined. If you have children, you have 4 children, you look at them and you'll see different attitudes to food, fed by the same parents. One eats to live, one lives to eat. I mean, it's like, what makes you do that? And I'm going to talk about that. Now, I'm not giving us a get out of jail card. That's not what I'm saying. I'm not saying 007 license to kill the food. It's my genes. No. What I'm saying is, rather than feel that I can't help, this is all my fault, I give in, that, okay, this is how I was born. Now, and I can't do anything about that, but I can do anything about other things. Does that make sense? Yeah. So how do you know you have diabetes? The one funny thing people tell me is that, oh, I'm gaining weight. My blood sugars are high, I'm gaining weight. No, when your blood sugars are high, you actually lose weight. People don't realize that. You waste your calories, you pee. But when you are overweight, it may lead to diabetes, insulin resistance, if you have a genetic tendency. Okay? But it doesn't mean when you have high blood sugars, these are symptoms are what you present with. And this is just a few: excessive thirst, weight loss, blurred vision, fatigue, sexual problems, weakness, numbness in the hands and feet, moodiness, dry skin, difficult. So diabetes can affect everything from your head to your toes, every part of you. Abnormal cycles, pregnancy losses, etc. What does your doctor see? In other words, that's what we call signs. A change in weight, sudden weight loss, the high blood sugars, of course, the abnormal blood test. They may check your feet and see, loss of feeling in the feet, weakness in the muscles. I always have a tuning fork. If we have a tuning fork in our rooms. A medical student said to me, I didn't know anybody used that. I said, every day. I use it every day because sometimes you don't even know you've lost feeling. But when we put it on your toes or the small filament, you can't feel it because of high blood sugars, because it's like poison to the nerve endings. Many years ago, we didn't have anything called pre-diabetes. When I was in training, that concept did not exist. In those days, your fasting blood sugar was 140 or above for it to be called diabetes. Then World Health Organization realized, wait a minute, by the time people are showing up with diabetes, they already have blindness, they already have heart disease, kidney disease. Let's start picking them early. So they lowered that fasting blood sugar to make a diagnosis of diabetes to 132. And they felt we were still missing a few people. So they lowered that to 126. That if your fasting blood sugar, and I'll bring that up later on, is 126 or above, you are considered consistently, not one time, you are considered diabetic, that you have type diabetes. Then they said, you know what, there are a few people that don't have diabetes yet, but their body is already working very hard because they are, and they don't know it, and they are feeding it, and they're living their life. If we pick them, we can stop the progression to diabetes. That was the whole idea of what we call the diabetes prevention program study. And that's the stage before diabetes. It's not pre-diabetes. It's not borderline diabetes, because there's really nothing like that. It's truly pre meaning before. So the blood sugars then are not abnormal, so to say, but they established that the fasting blood sugars are less than 100. At that time, they are about 100 to 125. Fasting, they are fasting between 100 to 125. The 2 hours after, but that's actually a wrong slide. I apologize. Normal is less than 100. The fasting will be between 100 to 125. 2 hours after food will be 140 to 199. No symptoms. You don't even know you have anything because you wouldn't, because your sugars are not high. But someone at this stage is drinking their regular soda, is eating their French fries, is not exercising, is living their life. And this, in the US, we think there are about 84 million adults ages 18 and above that are there. That's 1 out of every 3. But what the studies show is that if you catch them, if you could let this person know, not everybody, but they may not progress to the full-blown diabetes. Even if they do progress, it may slow it, it may slow it down. Maybe later in life, maybe they're already 80 or something, they're not the burden that we have now. Who is at risk? You see what I was saying? If you're overweight or obese, you are 45 or older, if you have a family member with diabetes, you are any of those ethnicity, you could be at risk. You're physically inactive. If you have high cholesterol, high blood pressure, you have a history of gestational diabetes, you had a stroke or heart attack, polycystic ovarian syndrome, which also has to do with insulin resistance, or you have any of those things, large waistline. It's not how you carry your weight, it's not how much you weigh, but how you carry your weight. So those are people that you would think pre-diabetes. And many times when you see that, you're looking, okay, you don't have diabetes yet, but this is when we want to catch it, because we want you to start changing your lifestyle. Nobody's promising you may not progress, but we think we could slow it down. And I always tell people that when we slow things down, it could mean not needing medicine, zero medicine, to 1 or 2 medicine when you could have needed a lot of medicine. Okay. Normal blood sugar, really fasting, should be below 100 consistently. 2 hours after a meal, below 140. Meaning you eat a meal, no matter what you eat, we check it 2 hours after, should be less than 140. That's called random. Yes, ma'am.
So is this becoming this 2 hour post food test? Is this becoming, or is it being recommended as part of a normal physical?
So most will do fasting. They'll just come in and say they're fasting, yeah. But the reason I put the 2 hours is that you're at home, people check their blood, or they do a random blood work, which is common, maybe for other reasons. You feel bad, you go into your doctor's office, they draw blood, and then they see a blood sugar of 120. But you just had lunch. Now, that's not abnormal. Do you see what I'm saying? Yeah. And so, but even if it's 141 or 130, it means you had a bad lunch. But how often then we may say, come back fasting. This has also become very important. The pre-diabetes thing has become very important. This is that pre-diabetes that I was saying, fasting 100 to 125, 2 hours after 140 to 199. Okay, less than 200. Yeah. Now, this is also important. It may not be relevant here, but information is power, and you should know. Before now, if we saw this, our focus was just on type 2. We talked about a study called Diabetes prevention program study, where in that study, when they randomized people to placebo, intensive lifestyle changes, and metformin, which is where the metformin concept came from, those people, everybody got a lecture like this on how to eat, exercise, blah, blah, blah. Some got placebo. One group got intensive. They got called by the, intensive lifestyle changes. They got called by the doctor, by the nutritionist. You have to do it. Then the other group got metformin. The group that got metformin, they were able to reduce progression by 40%, which means 4 out of 10 didn't get diabetes. The group with intensive lifestyle, they were able to reduce progression by 60%. So we know lifestyle works better than even metformin. Of course, when I present this study to my patients, they go, yes, I'll do it. Give me the metformin as well. It's like, come on, I just told you. But in that, what they did in that study, we may not be able to do it in real life because they were calling, it was what I say, they had each person had like a personal trainer. Then they brought them back and retested them and they were good. Now, this is also important now. I just throw this in because you guys will be super diabetes knowledge owned people. Is because there's now a medication approved by FDA if it is type 1. So we couldn't do anything for type 1 in the past. So if we thought you had type 1, it's like, why are we checking? If you're going to get it, you're going to get it. There's nothing I can do. But there is a new medicine now that if we catch you as pre-diabetic and you have antibodies suggestive of type 1, if you have diabetes, we cannot do anything. It's over. We just treat you. There is a medicine they can do, which is like a biologic agent they can infuse for 2 weeks. And we usually send them to pediatric, which would delay the progression to diabetes. It doesn't mean they may not get it. Some, it will delay for years for some. I mean, these are people that will need insulin injections. Exactly. So even in my adults, I look for it. Because if I can catch you here and you have those antibodies, remember that autoimmune you were asking me, and you are that and you have those antibodies, we'll send you there to go consider that treatment. You may choose not to do it because it doesn't mean you have diabetes. If you have diabetes already, there's nothing, we just start the treatment. But if it's pre and you are autoimmune, like the type 1, you could qualify for that treatment, which can delay the progression of the damage of the cells. Prevention of diabetes, we've kind of talked about it. Increase physical activity, weight loss, healthier food choices, move more to lose weight, diabetes prevention. I've talked about that diabetes prevention program study and where the metformin came in. You remember I talked about that. That's where, so you'll see doctors. So patients come to me and they're very upset because they've been diagnosed by pre-diabetic and they can't take metformin and their primary care makes them feel like you're refusing treatment. It's not actually approved. There's no medicine approved for pre-diabetes. Does that make sense? If anything is really been studied, but it's that intensive lifestyle changes. But most will throw metformin because it does. It's weight favorable. It makes it better. Of course, the A1C will come down, but really what you're trying to do is prevent you from getting, does that make sense? Getting there. Yeah. By the time you are here, there's diabetes. Fasting blood sugar 126 and above, random 200 or above, symptoms of diabetes that we talked about, then we've made the diagnosis of diabetes. You hear this hemoglobin A, so they do hemoglobin A1C, which I was also a little bit, we don't really use it to make the diagnosis because people have different hemoglobin patterns. And people have anemia, their treatment, and so hemoglobin A1C is one of the last things. Hemoglobin A1C is a reaction between your hemoglobin, which is sitting in your red blood cells, and blood sugar. And it's 3 months history. So in other words, if you look at your blood today, it's going to take 3 months to replace all of your red blood cells. So we look at that reaction to see how your average blood sugar has been. And it's less than 5.7 is normal. Between 5.7 and 6.4, we call it pre-diabetes. And above 6.5 and above, we call it diabetes. Sometimes that's important when we're fighting for medicine for patients.
What's the highest diabetic A1C you've ever seen?
So you should say it depends on the detection, the limits of the machine. I've seen when it just says greater than 15. greater than 20. Which means that's what the machine can read. It can't read any higher. If I wanted to, I can have them diluted. And what it does it matter? Yeah. So you could see anything, and they're walking too by walking. Now there are tricks to that. You don't mean just for fun. There are people that their A1C is just it's not right. So like someone who's just had a blood transfusion, someone who's had anemia, is on iron, who is getting Procrete for kidney disease, etc. Hemoglobin A1C is not, yes. So they may be low, but it doesn't really mean. And I would say, sorry, someone who has liver disease and they kept telling her diabetes was good because her A1C was low. And when she came and I said, your blood sugars are not. What are you talking about? They've been 5 point something. Yeah, because you have liver cirrhosis, but your sugars are, and there are other tests we do. That's why the checking comes in, checking your blood sugars. We could keep, but what do we do for treatment? Diet is important. Remember, we can't do anything with the gene, but what you put in your mouth is important. You have no business have been diagnosed with diabetes, you're drinking regular sodas. Come on. That's just sugar. One time I pulled it up for one of my patients. I do it all the time. 1 can of regular soda, I think Sunkist is the one I checked, it's like 23 tablespoons of sugar. Now, if you don't have diabetes, you could fool around with that. But I always tell my patients, if I walk in here and we all come in here, it's flooding here, and that faucet is overrunning, and this place is flooding, and we say, oh, let's get it clean. What are we going to do first? We turn that off and start cleaning. So if you don't stop that sugary drinks, you just keep the faucet running. What am I going to do? I can't compete against 6 cans of Pepsi. You might as well, I don't want your money. Don't come see me. When you're ready, come back. And I always say to people, why do I zoom in on that? Food is different because food is an acquired taste. You grow up with maybe you like potato, maybe you like rice. I mean, you could talk to me about macaroni and cheese and potato. Doesn't move me. I don't eat it. But talk about white rice, and you see what but sodas, you have too many alternatives. Or sugar drinks, you could try on sweet tea, but I learned the hard way. I told someone, no more sodas. They came back the next time. They were drinking sweet tea. I said, it's like, I didn't even know to start adding that. Or they started doing Kool-Aid with sugar. It's like, what did you think I was saying? They said, you said don't drink soda. I said, what about that? So all those sugar drinks, they'll just spike you. Some of my patients will put their test strip in the sugar drinks. Oh, wow. Just to tell them. I had one do it. Just to see. And you'll see, just read high. I'm not against, if you don't have diabetes, our children once in a while, those things when we were growing up, they were not everyday thing. Am I wrong? They were not everyday thing. You did it once in a while. But now it's like 6. I have included it in my question. I ask everybody because it's amazing how many times I get yes. I didn't used to. Then I realized the sugars would go like this. Yeah. Okay. One of my.
That's the first thing I gave up. And I didn't drink a whole lot of them, but now I don't drink any of them.
Yeah, so if you give, sometimes I'll see people give it up and weight comes off, we need less medicine. Just giving that up. Because people do it a lot. Yeah, routinely. Yeah. I had one person said, oh, even if they pray for me to quit, I wouldn't say amen because she's going to keep. Yes, true stories. I hear all kinds. Of course, the education like you're doing here, medications we've talked about, and we'll talk about insulin, other non-insulin injections that you've all been hearing about, what we call incretin mimetics. They are not insulin. They are like a hormone that our body naturally makes. So that's the Ozempic, the Manjaro, the Trulicity by Ada. Truly, they have changed the world of diabetes. I won't lie, they have changed the world of diabetes. And they are not insulin, but they make you release insulin in response to food, and they promote weight loss. And guess another thing they do? They work in the brain, so they do affect the reward center to food. Which is, so people think, yes, that's part of why it helps. Yeah. Yes, ma'am.
Why would a doctor say you shouldn't take that?
Many reasons. That one. So they have complications. They have side effects. Yes, biggest.
High risk for pancreatitis.
Yes, they cause pancreatitis. They may. So some of the common side effects: nausea, vomiting, constipation, and inflammation of the pancreas called pancreatitis. They do that.
That happens often. Because I'm like, I don't care.
And they slow down the stomach. And I do this for a living, so I write it a lot. So every year I'll get 1 or 2 people, and for me that's not a lot. But again, I'm very select. We're already very selective. If I think so, if you've had pancreatitis before, the question is why.
I haven't had it yet, but
do you see what I'm saying? So, but you're on lanreotide.
Yeah, I take that because I had tumors. I still do now. My pancreas, and I just have the head.
Exactly. So that's the concern. So you've had a previous disease of the pancreas. So that's why I'm told not to take that. That's probably they're worried. Yeah, that you could. So they can cause the nausea, vomiting because they slow down your stomach. They make you feel full longer. They tell your brain you don't need food. They bind to different areas. So it's interesting. They work on the reward center. So many people this week, I think I've had 2 people who actually said they don't drink much, but they were able to turn down alcohol. One, she says she eats too much dark chocolate. Realized she didn't, when she's taking it, she doesn't really care about it. So we know it affects rewards because food is an addiction, believe it or not.
Oh, yes.
And I always tell the patients, I say, you want to judge your sister who is on crack. You have your own crack, so don't be so judgmental. You see what I'm saying? We comfort ourselves. We do everything around food.
And you have to eat.
Very good. That's what makes it worse.
Yeah, you can't just quit it.
Very good. You have to eat.
Your addiction and still do it.
And you still do it. So unlike, you're very correct. So like drugs, when I get those young people at about 18, I always say to them, jokingly, no smoking. I'm emphasizing, don't go start smoking, don't start drinking. You don't need that to survive. And that's why I always emphasize this. But food we do. So if you're already, an addiction is another thing that's genetically determined, that your brain just, I always tell people, and not judgment, I say, thank God I never touched any of those things. Because knowing my brain, I'll be the one, they'll have to pull me out of to stop it. That's just what it is. So you're right. And it's been shown, they're studying it, and then that's off label for different things because it does help that brain.
Do you know if they're looking into trying to get just that part that affects your brain so it doesn't affect your pancreas?
It's very good. Smart people. So the way medicines work is they have receptors. Again, I never say never. So these medications have receptors. I call them medication, but they are actually almost like biologic agents, you would say, because naturally we make GLP-1s. That's what we call them. We make hormones that are like that. They think that's why people that have bypass surgery, really gastric bypass, lose weight. So what they did in the lab is to make something similar to be stronger. So it binds to many medications work, hormones work in the body by binding to receptors. Receptors are like keyholes. So the keyholes are all over. So you would have to, as time goes on, that's a good point you've made. So we have Manjaro, which binds to 2 ones. It's we call it the twin incretin mimetic, GLP-1 and GIP-1. So it binds, I'm not going to lie, it's changed diabetes. My very first few, that was almost 15, 20 years ago, my very first patient, she developed diabetes, came to see me, and that was a blessing because she had tried to have children for years. And at that time, those medicines were just out. I wasn't planning for her to have kids, but I always say because she was fresh to me, I put the fear of God in her. And I put her on the first one. Without trying, she got pregnant. She had done IVF, couldn't have it. But she lost about 150 pounds. Wow. Plus everything else that we taught her, and she was young, yes. And so they'll laugh. I said, this blonde baby is my baby. They'll call them, we'll laugh, my baby. And when it comes in, then she had another one. Within 2 years, she had 3.
Wow.
So this has changed so many. Yeah. My point is that it's we don't think it, we don't know. I'm not saying makes people, but the weight loss kind of improved her PCOS, the police, and everything. So we know it does. Those are off label. I don't talk for any drug company, so I can say what I do. Yeah, those are things we are learning. And I gave a lecture to psychiatrists about this just to see, and they had all kinds of questions because they are looking at it in dementia, in addiction. We don't know. Yes, we don't know. But I'm just listening to my patient. Yes, my patients, the first few patients will say to me, and I remember the lady said, oh, it took away the food noises. Exactly. I had someone, very smart person, send me a message and say, for the first time in my life, I know how it feels to be full. I mean, they're not making it. I asked another one. I said, what do you mean? And I remember that patient said, when I finish eating breakfast in the morning, I'm thinking about lunch. On this medicine, I don't.
That sounds a lot like tobacco.
Exactly. Yes, yeah. And so we don't know. It's a great drug, but they are suing them and they have great benefits, but they have side effects. And that's why I put that this was one of my last slides. I said, you know what, we should talk about it. They cause nausea, vomiting, pancreatitis. It can cause inflammation of the pancreas. In the lab, in some laboratory rats, a form of what we call C-cell hyperplasia, a form of thyroid cancer. So if a patient has had something we call MEN, multiple endocrine neoplasia 2, we don't use it. Yeah, if they've had pancreatitis. Of course, if you have pancreatitis from like gallstones, we could use it. But if so that's why they wouldn't use it. Because it can, in fact, I just got some news from England, they're kind of slow on, and we are bold. This nurse died because she took Ozempic and got pancreatitis. I said, she must have got complicated because I don't give people Zofran or something for nausea when they take it, because most people won't tell you they're throwing up because they want to keep losing weight. So I don't, I let them tell me. Do you see what I'm saying? I don't treat the nausea. I say it should stop because the nausea should stop. Apparently, this nurse in England kept checking it. She got pancreatitis, got septic, got very sick. So they are not as innocent as we think.
And the doctors should have been more educated whether or not to have her
stop it. And that's what I was just telling you, that many people don't want to tell you because they don't want to stop it. Now, the other thing I'm saying, in case anybody puts any of you on it, is like, who told you have to get to the highest dose? You don't have to get to the highest dose. If it helps you so you start a low dose in the least time and you can move it up slowly.
Because for the diabetes part, it is a lower dose.
No, not from all of them. Not for all of them.
Maybe the one that I read on, and I don't remember which it was. And then for weight loss,
it's a high, but no, not for semaglutide and
what's that, GLP or
for GLP, GIP, the same. Not for Mounjaro. Mounjaro is the same as Zepbound. It goes up to 15 milligrams. Ozempic is the same as Wegovy. The Ozempic goes to 2 milligrams. The Wegovy goes to 2.4 milligrams. It's the same. The only one that's really different is Victoza, which is liraglutide. The diabetes one goes up to 1.8. Sorry, I apologize. This is the time home. And I thought I turned it off. So the liraglutide goes to 3 milligrams. Yeah, so, but yes, it has. And I knew that would come up, Then, of course, I put surgery there because there are times people get diabetes from all those secondary problems that I was talking about, like Cushing's disease. I love to see that because you can get them off medicine once you cure it. So sometimes we look for it. Cushing's, acromegaly, growth hormone excess, tumors on their pancreas, other things, and you can take it. Then we talk about how to give insulin. You guys are familiar with that. We've talked about this. We'll talk about pills again. The devices, there are different devices to give insulin. I thought I actually have. At this point, we will say the devices include, the pens, the vials of insulin, which I thought I actually had. We have needles and syringes. That's what we're familiar with. There's a show on TV called The Midwife. And in those days, I don't know if you've seen it, where the nurses will carry the insulin in a glass bottle. Yes, so we've come a long way. So we started, when I was in training, We use needles and syringes. When the insulin pens came, we got so excited. I think I was in fellowship. Then now we have insulin pumps. Inhaled insulin came where you can just inhale, but it didn't really do very well. It didn't hurt, but no most of us didn't ride it because to even get anybody that would qualify, it was so. But we know that's going to come. So there are going to be other modalities. The insulin pumps, it's come a long way. It gives insulin continuously. It talks to your continuous glucose monitor, which I'm going to talk about, and it's almost like AI. It just tells you what to get. It just, you don't even have to put it in. Yes, ma'am.
Mm-hmm. I was on Ozempic. Mm-hmm. She tried me a different one. My A1C is 11.3, and it's been like that the last year, over 11. So now they're moving me to insulin pumps. Is the medicine and the pens and the medicine and the pumps, are they comparable or are they different?
So the pump is just a mode of giving insulin. It's just a way of delivering insulin. Okay. So insulin pen is different. Insulin pen is insulin in a pen form. Right. And they did that for convenience. So you just have to dial and just inject. The insulin pumps holds insulin that gives you insulin continuously. And they'll use short-acting insulin. I'm going to come to that. So actually, different types of insulin. So you have the broadly, this is broad. You have long-acting insulin, which is your foundation, once a day or twice a day. Those do not go in the insulin pumps because you only get, then you have the short-acting insulin, which kicks in about 30 minutes and it's gone in like 6 hours. That's your regular insulin. Then you have the rapid-acting insulin, which we say it kicks in about 10 minutes, 10 to 15 minutes, but they are gone in 4 hours. Those are your Humalog, Novolog, Insulin Lispro, all of those. Then you have the ultra-rapid. These are supposed to be very quick. They claim that you can even take them after the meal and they still work so quickly or while you're eating. Then you have the very concentrated insulin for people that need large amounts of insulin. So most insulin that we have, 100 in this country, some other countries have smaller concentrations. 1 cc, 1 ml of insulin has 100 units in it. That's why you can just dial. Now, if you're using a lot of insulin, that's a lot of volume to inject. So we have the more concentrated insulin, the U200 in 1 ml, it's 200 units. In the U500, in 1 ml, it's 500 units. Yeah. So, in fact, I was just talking to someone today and I said, I'm going to use what you said. So the U200, it's like having 5 $1 bills versus 1 $5 notes. If you see, you have $5. I have 5 $1 bill to stuff in my purse, and you said, I have a small wallet, just give me the 1 note of $5. So it's more consent. It's the same amount. Do you see? That's kind of how the concentrated ones look like. Now, the insulin pump that you are asking holds the rapid-acting or the short-acting insulin. We don't put long-acting insulin. Think about that like when you're getting an IV drip in the hospital. It's continuous. It just gives you insulin continuously. Yeah.
Are those higher concentration ones, or those more type 2 versus type 1? Or are they more type 1?
You could use them in anyone, but they tend to be used more in type 2 because it's usually in people that are very resistant to insulin and they need a lot of insulin. So like I have some people who take 200 units twice a day. The whole day they're using 500 units. That's a lot to inject. So you want to use the concentrate. Does that make sense? Pardon?
I said you can really go through those pins.
Exactly. That's why. So the U500, you can imagine. So it didn't used to come in a pen, but now it's in a pen. So when you dial, that's in 5. It's in multiples of 5. So like 5, 10, unlike the ones you have now, 1, 2. You see,
they 20. Mm-hmm. 20. Are they considered units on each click on your pen?
It's 1 unit usually. Now there are the junior pens. There are junior pens for children which have half units. You could do half of a unit. The adult quick Tresiba. So your Tresiba is either a U100 or a U200. The U200 has 200 units in 1 ml. The U100 has 100 units. Do not pull it out of the pen because when you do, you'll overdose. So it's already programmed that if you dial 2, you're getting 2 units. but your 2 units is really like 0.1 ml exactly. Somebody else in the U100, their 2 units is really 0.2. So you have a more concentrated, so that you don't have to have so much under the skin. Yeah, that's really why it is. Yeah. And blood sugar monitoring at home, very important. We're familiar with glucometers. We have them in all kinds. I always tell people, you have got to check. If you don't check, there's no way to know how you're doing. It's like telling me to drive here today, or you telling you to drive home and I blindfold you. Nobody's that good.
So we should check our urine for glucose.
I put that there on purpose. I wasn't sure if we have type 1. That's good. If you're type 1 and it's good to have that at home. That's so that if you're high, it's going to be a difference on should I stay at home or should I go to the hospital. Yeah. Yes, like a urine.
They told me to get the sticks, but I'm type 2.
Really, you don't need, because the chances that can type 2 go into decay? It's possible, it's rare. Rather, type 2 tend to do what they call non-ketotic hyperosmolar, which means their blood glucose goes so high, their sodium, and they can become comatose too, but they don't build up. Because to have diabetic ketoacidosis, you have to be deficient of insulin. You don't have insulin. But exactly. So type 2, they have tons of insulin. It's just not working well. Yeah, and we didn't kind of go into that. The home hemoglobin A1C kits, I put that there. You don't really need that, but because it takes 3 months to change, but some people like to have it. But you can get it over the counter. You can check at home. Just with the blood drop, it gives you some insurances now give it to their patients to help them to monitor. Yeah. Then the continuous glucose meters are now the popular. They've changed the management of diabetes. And I didn't think that would happen in my time. What did I know? You don't have to stick yourself to get your blood sugars. Yeah. It's the best thing. I would fight for my patients to get that. You put.
When I started just a few months ago with that, I don't know why everybody isn't allowed to have it.
I know.
Because it makes me more aware.
Yes.
I might stick my finger in the morning and it's like, I'm clueless,
But you see it all the time.
Whatever, but on that, I check it all the time. It's like, okay, I'm going to eat. Let me see oh man, well, it makes me think twice.
And you know how different foods affect you. Oh, I ate that. That was good. See what it did. Yeah. And it has alarms.
Oh, yeah.
That's crazy. Yeah, there are tricks to that, but you can't turn it off. Off, yeah. You could try to turn it off. Yeah. Yeah, but so the Libre, yeah, it goes off. Yeah. It's loud. It can be disruptive. You have to raise that. You have to raise the limits. Yeah. It's so loud. Yeah. So the Libre, you could wear it for 14 days. Now they have the most recent 15 days. And you change it up. You can take your shower, swim with it. The Dexcom, when it first came out, if you took Tylenol, it interfered and they moved quickly. Now we have the G7, where 10 days, you put it on your arm, G6 on your belly. Yeah. I put the Eversense system. I don't use it. Eventually, I think if they could master it, it's actually not a bad continuous glucose monitor, but you put it under the skin. And you have to, exactly. So when I learned about it, they showed it to me. It's like, I have to cut on my patients every 90 days. You've got to cut, yes, you cut, insert it, then sew it back. But then you don't have to, it's there. You don't knock it off, exactly. You don't knock it off. Yeah.
One fell off today and it don't.
Call the company, they'll send you another one. Yeah.
I don't even have the phone number. I looked on the box. And
look online, 800 number. Yeah.
Do you have the little covers for them?
Yes.
Oh
look online.
Lifesaver.
Yes, Lifesaver. Look online for the yeah. So those Evers, I put that there, and then the Medtronic have their own, which is called Guardian, which talks to their pump. Yeah, it is. That's why I don't. Yeah, but if you're using an insulin pump, now these have changed diabetes as well, because they communicate with the pump. They talk to the pump, and the pump regulates your insulin. So the pump looks at the blood sugar and say, okay, she's 130, but at the rate at which she's going to go very high. So it gives a little bit more insulin. Now it says 130, at the rate at which she's going to drop. So it pulls back a little. So it talks, there is a new pump where we don't even put any dose in it. It looks at this, learns you, and then when you wear it, you just tell the pump, I'm eating, and you tell it whether it's a small meal, a medium meal, or a large meal, and it knows what to give you. As long as you talk to it, it's really actually amazing.
If you qualify to get a pump.
If you produce, so Medicare has a rule that if you're still, really it's like they don't want to give type 2, but if your body still makes insulin, they don't want you shouldn't get the pump. Now, there's a way to get around that rule. The Omnipod pump, you don't go through durable medical supply, you buy it at the pharmacy. Nobody does a PA. All your doctor does is to write a prescription. But not everybody needs a pump. If you're not on multiple insulin injections, you don't need a pump.
You don't need anything. I'm having a trouble. I've got Medtronic, and so the problem they're having is with me. I'm actually an Anthem employee, and my insurance sucks for me. And, your benefits are decided by your company. Right?
Yes.
But so the Guardian part, I've got everything. The Guardian part is $180 a month, and the insulin is like 70, I think, every 3 months, which that's not a problem. But 180 plus they wanted me to buy a monitor thing for $456. This is all after insurance.
Insurance.
And then the pump itself was after insurance. My part was $2,500, and I told them, I can't do that.
No, can't do that.
They knocked it down to $900, and I'm making $25 payments.
Oh my Lord.
So I mean.
But why did they look at other pump devices?
I don't know. It's Medtronic, so I don't.
But there are other pumps. I mean, it depends. So that you said, why is everyone not on this? You just said the answer.
Yeah, it's awful.
It's because of the cost. Because of the cost. They're going to make, I think one of them is going to come over the counter, but it ain't cheap.
No.
Yeah, it's not cheap. Why do we treat? We've already talked about it. I always put it there, to live a productive life, to fulfill your destiny, to enjoy what God has given you, not just to live your life and not be blind, and not, because people now live to be 90, to be have their normal lives. Judges, lawyers, doctors who have diabetes, because of all these things. That's why I talked about Still Magnolia, that things have changed. If you remember that movie, she died of low blood sugar. She was already on dialysis. Yes, she was at home or at work or something like that. And every time I think, maybe there was nothing to. Now on those continuous glucose monitor, you could even share with your family. So they're actual, yes. So like one of them, Dexcom, I believe, your husband can have your data. So he could be at work and you're at home, and he'll get the alarm. So exactly. So imagine this for children. I mean, there are kids in those days, their parents won't sleep. They'll leave the door open. They're just so scared. Yeah. But now it's like, get this. It will wake them up. They have it on their phone, just like the kid has it on their phone. So you see, I mean, we know the chronic complications. I don't want to be, we already talked about it. Stroke, heart attack, blockages in the vessels, kidney failure, loss of babies, loss of, if you smoke, please quit. It's the worst thing you can do when you have diabetes. I always say the best thing you can do when you have diabetes, apart from taking your medicine, is exercising, keep moving. The worst thing is smoking. That thing just clogs up vessels. It just clogs up vessels. We've talked about monitoring. What do you do at home? Check your blood sugars, check, monitor your blood pressure, take your medicine, exercise regularly. Now, people get better and they go, am I cured? My A1C is 6 point something. Can you be cured? No. Not really. Now we're changing that. They're saying it's possible, but for us to say you are cured, so when people say, I'm actually cured, I say, okay. For us to say you don't have it anymore, you have to be without medicine for 1 year on a regular diet. Who wants to do? Yes. And your numbers are normal. Exactly. So who are you trying to prove it to? But if you come down off, we can reduce medicine as things get better. Yeah, so but imagine if you had a different reason, like maybe a growth on your two-part adrenal, yes, if we treat that, you could be cured. Do you see what I'm saying? Yeah. From secondary, exactly. Yeah, but then, yes, you got it. So I'm always very, we've talked to, Dr. Jargon's hemoglobin A1C. We talked about that, your cholesterol readings, they check your total cholesterol, your LDL. You want L to be low, LDL to want it low. Low is good there. HDL, you want that high. That's your good cholesterol. H high. That's how I teach my patient. H high. You want H to be high, L to be low.
You know how I do it? H is healthy.
Good. I even like that.
L is lousy.
I like that. I like that. I like that. Yeah. So that way you look at it, yes, and say, okay, well, how do you rate? That also has some genetic predisposition. Some people HDL is low, but exercising, walking raises HDL, not smoking, and of course medications. Yeah. We check your blood pressure. We check for urine for microalbumin and creatinine to make sure there's no sign. And do I need insulin? Do I not need insulin? We've talked about it. Comes down to, do you produce enough insulin for what you need?
That test, that creatinine, isn't that a test to see if you're producing any insulin?
C-peptide. You're talking about C-peptide. So the urine microalbumin creatinine is in the urine to look at the ratio. Normally, it should be less than 30. So because it's like the early sign of diabetic kidney disease. So you'll see, we'll do it once a year if it's normal. Yeah. But you're talking about do I need insulin? So, well, look at your blood glucose. So to measure if your body is making its own insulin, there's a blood test we do. And see, because if you are not making much, if the factory house is not working, all the medicines we give is on one assumption: your pancreas can make insulin.
I know that's one of the things to get a pump. You have to prove that your
pancreas does not make insulin. That's what Medicare says. Yeah. The commercials don't. Really, that's me talking. It's really not fair, because there are some people that would need insulin for the rest of their life. What they are producing is not enough. So if you're doing multiple injections, but the Omnipod bypasses that, because you don't have to go you don't go through DME, you just go to the pharmacy to buy your Omnipod. So you can get the Omnipod 5 without checking for that. But if you're not doing multiple injections with your meals and base, is it really necessary? Yeah, that's the question. And about this blood pressure, but at the end of the day, we don't have to go into blood pressure. Monitor your blood pressure. The only thing that can cause headaches. But I'll go on to talk just the diet to stop blood pressure. Diet rich in veggies, low fat dairy, whole grain, poultry, low in sweet. We've kind of talked about all of that. The kind of diet to talk about. Yes, the kind of diet, because uncontrolled high blood pressure can work with diabetes, and they can cause all those things. The DASH diet limits salt and the hidden salt. Most of us, we may not put salt in our food. I was watching my hands as I ate a salad. I think it was so salty. Sometimes just your salad dressing, if you're not careful, it's just so salty. I mean, these are the things you want to avoid. The cheese, the ice cream, all those trans fats, all those things we all like. Yeah. Because we want to avoid them. Yes. Now, remember I said I give this to other international people. So in some cultures, they cook with palm oil.
I've never heard of it.
Yeah, they cook with palm oil. So, and people come here, live here, but they still want to live the same way, eat the cheeseburgers. I still do that. It's a double whammy, yeah. But these are substitutes to raise good cholesterol. Fish, avocado, nuts, different olive oil. The goal, you want to reduce the saturated fat. Yeah. And ideas: eat nuts instead of cookies, add avocado to your salads instead of dressing. We're just talking about that. And replace your butter and solid fats with olive oil, canola, avocado oil. Just ideas on how we just have to change our way of thinking. Yeah. Yeah.
Would you suggest to put on toast then?
I know.
You're not supposed to use jelly, you're not supposed to use butter. I use butter. But
you have all those. I don't believe it's not butter. Like with canola or made with olive oil, canola. I know. So the best, yes, the best thing is avocado.
Oh, you should try the Dunkin'. They have it. They never give you an idea if you like it or not.
Yes, which one?
Dunkin' Donuts.
No, they have with avocado.
Yeah.
Oh, you see?
Avocado toast.
Yes, if you toast it and you put a little, you know, some people can't tolerate it. Is it good? Yeah. Even people put it on their sandwiches.
Yeah.
Particularly if it's toasted and you just kind of slice it on it. Yeah.
That's the meal that's on our list.
Mm-hmm. And it's good fat.
Yeah.
Peanut butter is good fat, but it's high in calorie, and then it's all you could grind yours. So yeah, exercise. I put the smoke. We talked about limit alcohol, exercise regularly. You just have to incorporate it into your life. These are some apples, green beans, but you got to be careful for fruits. I'm sure you've all learned that fruit spike insulin. They're high. Peas, beans, lentils, nuts. You've got to be careful for oatmeal. It spikes blood sugar. It's okay, whole cod, when you make it small portions. Small portion. You check, eat a good bowl of oatmeal, no sugar, nothing. Very high in carbs. Kind of like banana. Banana is good, but you have to do like half of it. Yeah, it's very high. Well, kind of like your bagel. People think one bagel is like 3 donuts. I told that to one of my bitches. I said, I'd rather have the donut. I said, that was not the point of that. I was just telling you. Better, eggs are also okay, but you can't have yolks all the time, particularly if you have very high cholesterol. Just yeah. But these are just ideas. Just not how you shop. Avoid convenience. Yeah, and just yeah.
We're starting to do. We like to eat. We split a meal.
Yes, that helps too. You split a meal.
And I'm full.
Yes.
I would sit and eat all of it.
Yes, sometimes it's just you're not even thinking. You just go, yeah, just yeah.
It's cheaper.
Is it? And I always put this. I don't, not trying to put religion into it. That was not my intention. But this is, I said I give all over depression, anger, stress. All those things affect blood sugar. I always say I watch my patients, and that I've learned a lot from my patients. If there's stress in their life, they don't even know. They think they're handling the stress, and the sugars will just go.
I feel that.
Do you see what I'm saying? You think you're good. So I always put this exercise regularly, ask questions. I embrace questions. We dialogue with my patient. I love it. If I don't know, I'll tell you I don't know. I'll go look it up. I'll call you back. Go on vacation, be thankful every day. We are here to still have a conversation. Enjoy your life. It's not a burden. We just want to do the best we can. We just want to do the best we can. Do the best we can. Yeah. Thank you very much. Thank you.
Thank you so much for watching this episode of the Diabetic Defenders, Building Your Defense Against Diabetes. We hope you'll join us for the rest of the series as well. Click subscribe on the Facebook page or Instagram and YouTube, as well as Twitter. We look forward to seeing you next time. Bye.